I'm Nick Savva. I'm an orthopaedic foot and ankle surgeon. I work here at Fortius in London, and I also work in Dorset in Dorchester. I specialise in all aspects of foot and ankle surgery, including trauma, sports injuries, arthritis and toe deformities. Good evening everybody, thank you very much for coming. So I decided to talk about Lisfranc injuries. I've seen a few of these recently at home. So windsurfing, I don't know if any of you know about windsurfing. Windsurfing is a sport that's been around since sort of the 60s and 70s. The thing about these characters that do this sort of thing is they have their feet in straps which are quite loose, so your foot can come out of them relatively easily. Of the serious injuries, most of them are lower limb injuries. Obviously there are some pretty nasty things that happen. Wakeboarding is altogether different. You're pulled along by a big powerful boat and you're actually strapped in very hard. I don't know if any of you have ever had a go at this, but you actually have to use something like fairy liquid to get your feet into the bindings because they're so tight. And so we see 1 or 2 patients every year with a fracture of their tibia, rather like skiing, just above the bindings. And interestingly, a fair number of knee injuries, ACL and MCL injuries, because one foot often comes out, leaving the other with this huge lever arm on that then twists their knee. But again, you do see the odd foot injury because the sportsmen jump and land awkwardly on their feet. But then again, there's all these other odd injuries, including fingertip avulsions from holding onto the rope or wrapping your fingers around the rope. Kitesurfing is very, very popular, more popular than windsurfing, and is very dangerous when you're on the beach. The kite pulls you along, which is extremely powerful, and when you're on the beach, if the wind catches it or somebody launches your kite, you end up being launched over the car park, over the road, all sorts of terrible places. The foot is relatively well protected in kitesurfing because it's just in a soft strap on a board that falls off relatively easily. But rather like wakeboarding, sometimes one foot comes out, causing regular knee injuries. The majority of serious injuries, however, are feet and head injuries in the car park. Skimboarding, I love this picture. Skimboarding, the average age of the skimboarder is under 16. So this bloke is clearly trying to look under 16. But interestingly, what you do is it's based on the premise that you put a board on the water that's aquaplanes and you jump on it and it skids along. But if you watch someone doing it on the beach when they're learning, occasionally it sticks hard and they just fall straight over. So most injuries are broken wrists and broken ankles in kids. Surfing, it's quite hard to hurt yourself surfing actually on the board because it gets washed away. The commonest injuries are head injuries from being hit by the board when the leash comes and wangs it back, or being hit on the bottom. Lisfranc injuries were originally described in people that rode horses. This is where it gets really tenuous, like a horse in the water. Because of the foot in the stirrup. So the foot's in the stirrup across, you're supposed to just have your toes in, but occasionally if you fall, your whole foot goes in or your toes get caught, and then of course you fall off and your forefoot is twisted on your midfoot, or your midfoot is twisted on your hindfoot, causing these injuries. This is where the name comes from. This French chap was a Napoleonic surgeon. I actually requested the French language paper, but then couldn't translate it. But he actually was supposedly Napoleon's surgeon. I think he was actually just a Napoleonic era surgeon who described the joint and injuries to it. And of course the treatment then, because a lot of these injuries were compound, was amputation. So onto the Lisfranc bit. So where the Lisfranc joint is here. It's the joint between the tarsometatarsal, the metatarsals and the cuneiforms and the cuboid here. And it's sort of the most important part that forms the medial longitudinal arch and the transverse arch of the foot. And that's maintained by the shape of the bones. So you can see they're triangular, rather like keystones in a Roman arch. And then in the transverse plane, the second is set back rather like a keystone in an arch. And so it's a rigid, bony structure. There's 3 columns, or there are said to be 3 columns. The medial column is really quite mobile, with sort of 10, 15 degrees of up and down movement in most people. The middle column, which is the second and third, is really quite stiff because of the keystone effect. And the fourth and fifth are really very mobile, with 30 degrees of movement. Now, it's quite understandable why the medial side is so mobile when you consider what we've evolved from. Our foot originally was used for grasping things. It's not opposable like a thumb is, but you were certainly able to do a fist sort of grip with our thumb when we were still essentially climbing trees. And we've evolved over to a foot which is a much more stiff platform, which allows side-to-side movement for walking on an even ground, but as soon as we go to push off, turns into a stiff peg that we can push off from. But there is still relative mobility in the first ray, which explains the anatomy of the ligaments. Oops. So the anatomy of the ligaments is interesting. The dorsal ligaments, rather like on the wrist, are weak and not terribly important. The intertarsal ligaments, so the ligaments sort of deep within the foot, are very significant. So there are intertarsal ligaments for all of the metatarsals, except one between the first and second metatarsal. And that's because this is still relatively mobile from the day when we were using our foot as a fist. And in fact, if you think about the first ray, there's only 1, 2, 3 bones before here, isn't there? And in the others, there's 1, 2, 3, 4, and then this. And so this Lisfranc ligament, the intermetatarsal ligament, is actually the equivalent of the intertarsal ligament if you look at it phylogenetically. On the plantar surface, there's another very important ligament, the bifurcate ligament, which goes from the medial cuneiform to the second and the third, and you occasionally see avulsion fractures of these. And so we probably should think about a complex of ligaments and a joint that transverses the whole midfoot. Just while I've got this slide up, it's very important to look at the alignment. You never see this view like this on a plain x-ray because of the arches. If you take a view down through a foot, you never see that lined up as it is. But you do if you take various oblique views. The most important thing if you ever get presented with an x-ray from somebody that comes back from a water sports holiday or a skiing holiday or whatever, is the alignment of these bones. So the first always aligns with the medial cuneiform, sorry. The second with the middle, the third with the lateral, and then the fourth and fifth with the cuboid. And that is invariable. The gaps vary, and I'll talk about that a bit later, but those alignments are very regular. So the mechanism of injury varies considerably. Something that we see more and more these days because we're becoming much more aware are subtle injuries in athletes. So the mechanism in those people is usually a twisting movement on a loaded forefoot. The commonest way of doing it is a car crash, actually, these days. But having somebody land on the back of your foot, so this is a classic sort of American football thing, you're kneeling down, doing something on an American football pitch and somebody lands on the top of your foot. That's someone falling out of the stirrup of their horse, and of course a windsurfing foot strap. 80% of patients with these that present to us are multiply injured from either a fall or a jump or a car crash. But the sports injury thing is becoming much more common because we're getting better at spotting them. So how do they present? Well, the multiply injured patient is pretty obvious because their foot is very swollen, and we'll have picked it up early on in their sort of secondary survey of the ATLS thing. But in the sports injury patient, you need to be very aware of this bruising on the bottom of the foot. Somebody with a normal soft tissue injury to their foot or their ankle won't have bruising on the sole of their foot because you need to have ruptured either the plantar or the interosseous ligaments to get blood flowing down into the sole of the foot. So look out for that. They have a tender, painful midfoot. They often say that their foot feels unstable, and what they're describing is the midfoot collapsing as they stand on it. Athletes are many athletes are very stoical, and so they usually shrug it off and try and get on with it. Don't forget there's another foot to compare it to. And then again, don't forget you can injure both at the same time, particularly people who are in foot straps with both feet. So the multiple injuries are pretty obvious, pretty easy to pick up. On the first examination, that looks normal, doesn't it? Until you realise that should be there. So this guy jumped off a bridge, did this to both feet, and you can see the second is smashed to smithereens. And so the alignment's completely wrong. That bit of bone there should be there. But interestingly, the fifth, look, is in the right place, fortunately. This is much more subtle. In a patient with a bruised foot like we just saw, we'd always take an x-ray, and you sometimes see this little flex sign. Can you see there's a little avulsion of bone there? And actually, when you look a little more carefully over this side, it doesn't look quite normal. And there's a reminder of the alignment of what it should look like, in that the edge of the second metatarsal should align with the medial side of the middle cuneiform, and it's not. But you've just got to be very vigilant to see them. Sometimes taking the patient to theatre and stressing the bones is the only way you can find out if there's instability. So you can do CT scans, MRI scans and so on, but this is a very useful way, if you're planning on operating on them, of finding out if something's subluxing. So you can see here the first metatarsal has popped up compared to the middle cuneiform when I've got hold of his foot and wrenched it in front of an x-ray machine with him asleep, because you'd never, of course, do it with them awake. And you can also see an avulsion there with the eye of faith of the plantar surface of the second metatarsal. The reason it's difficult is that some of these gaps are very variable. The gap between the first and the second metatarsal, if you read various papers, is measured anything from 1 to 3 millimetres. Weight-bearing views are extremely important at loading the foot, so you need the patient to be able to stand on it. But here, you get the impression that this is abnormal. It looks sort of 2 or 3 millimetres to me, so I'd have a high index of suspicion about that foot. So I always get a comparative x-ray of right and left, which causes the radiographers to jump up and down because they really don't like taking x-rays of the normal side, but we insist in this situation. CT scans can be very helpful in surgical planning. Here you can see, again, you can reconstruct the slices in any plane you like, and you can see that the first metatarsal isn't lined up with the medial cuneiform, and there's actually a fracture of the base of the second. It's left its keystone bit behind and translated across laterally. For the very subtle injuries, MRI scans can be extremely useful because you can actually see the ligaments if you have a really good radiologist helping you, and that's a normal Lisfranc ligament, so the intertarsal ligament. So the major injuries are classified by Meyerson, who's a very famous American surgeon who's published lots on all sorts of different things. And these are about the patients that jump or in road traffic accidents. So in a really bad situation, the whole lot goes, often leaves a bit of the second metatarsal behind, and it can go laterally, it can go medially, and these are disastrous injuries. Sometimes, like in that chap that I showed you, one part is left behind, which is called partial incongruity. So the medial side can fracture off, or the lateral side can fracture off and drift, and that obviously depends on how you land or the deforming force at the time of the injury. And again, devastating injuries. And then the third part is where one goes one way and one goes the other, which requires a degree of force even further, which is, again, a devastating problem. The minor injuries have only recently been classified by Nunley and co. They base this on plain radiographs, clinical signs, and bone scans, interestingly, but you can extend that to an MRI scan, really. Stage 1 injuries are essentially a sprain with no deformity. So there's an injury to the Lisfranc ligament complex, a bruise on the bottom of the foot. They don't like standing on it, but the ligaments are intact, so you can treat it like a sprained ankle, essentially. And I'll talk about that a bit later, the treatment a bit later. Stage 2, which is a bit like the x-ray we saw earlier on, there's 2 to 5 millimetres of diastasis, so there's partial or complete rupture of that Lisfranc ligament, but it's mostly reduced. And when they stand on it, the gap opens up, but the foot doesn't truly flatten. And stage 3 is greater than 5 millimetres of diastasis. And when you look at a lateral standing view, you can actually see the middle of the foot sag on the x-ray. So what are the principles of treatment? Well, the principles of treatment of any sprain or fracture are to preserve the anatomy and function while the body heals itself, aren't they? And to avoid this situation. So if you leave an unstable midfoot, you end up with degenerative arthritis across the midfoot. So you can see here a sag in the middle of the foot. If you draw a line along the first metatarsal and a line along the neck of the talus, it should be a straight line. It's called Meary's line, and it should be a straight line. And you can see a sag in the middle there. And when you look at the AP view, you can see 3 of the 4 radiological signs of arthritis, in that there's loss of joint space, cysts, and subchondral sclerosis. The only thing you can't see is osteophytes. And so I can't promise you this is an old Lisfranc injury because I found it last week in clinic, but it's the sort of thing you do see. So how do we treat them? The most important thing is to pick the subtle ones up early on, because we know that leaving them and missing them, they do badly. So basically, you've got to pick them up early and then treat them. So you need a history of something that's going to likely to have caused it. So a loaded twisting injury of the middle of the foot, tenderness across the middle of the foot, normal weight-bearing x-rays or stress radiographs, which we repeat at a couple of weeks if they're still sore, to diagnose a grade 1 type injury. And if you have a grade 1 type injury, I would just rest them in a boot for a couple of weeks, reassess, and then get them going, possibly with some sort of orthotic arch support, aiming to get back to sport at somewhere between 6 weeks and 3 months. Treatment of the unstable injuries is much more controversial, and there's an awful lot in the literature which doesn't make it absolutely clear what you should do. If you have a significant displacement between the first and the second metatarsal, the injury isn't reduced, and so you need to reduce it. That's the theory. But how much displacement do you need? And that's where the real arguments are. And these are the patients that we take to theatre and stress the foot and then decide on the table exactly what we're going to do. Sometimes you can reduce them perfectly and put percutaneous screws across to hold them in place. The problem with that is that you're putting screws through joints that are normal, which causes damage and therefore has the potential to cause arthritis. And the traditional screw that's put in is this screw to replicate the Lisfranc ligament, but we occasionally augment it with other screws if there are other lines of injury. And these screws often loosen. Can you see that sort of black halo around that screw? As the patient walks on it, they loosen and they sometimes break or need to be taken out. So you're condemning the patient to 2 operations potentially if you do it this way. Also, it's very difficult to guarantee that you've perfectly reduced it, and there's no point in doing an operation unless you are going to perfectly reduce it, because the risk of arthritis is so high if you leave them unreduced. And so there is, we all have a very low threshold for opening them, so you can see that the bones are in exactly the right place. And if you've opened them, then you might as well reduce them with a plate or something that bridges the joint and doesn't damage the articular surface. There are some folk that use these tightrope things. Now, you know the tight ropes that they use in the shoulder for popped ACJs and in the syndesmosis. There is a vogue for using those. Can you see one button there and one button there? It isn't terribly well reduced. And also this is a bioabsorbable screw, which obviously doesn't need to be reduced, but they're not very biomechanically effective. So what did we do with this unstable chap? Well, his second metatarsal was too comminuted to do anything with at all. And so we reduced it and bridged the joint with a plate and bridged the third with a plate and then put K-wires across the fourth and fifth to hold them reduced. And this demonstrates all the basic principles. You stiffen the medial column and the middle column because they're quite stiff already, and you put flexible fixation across the lateral column because it's quite good to leave a little bit of movement there. There's quite good evidence that if you primarily fuse these joints, where there isn't a huge amount of movement anyway, they're much more likely to get back to walking and potentially sport. If you are just reducing them, then again you're going to have to take the plates out, and so the patient's going to need another operation. And we aim to do that about 3 months, with the patient going back to the sport at somewhere between 4 and 6. So what do we do with these patients post-operatively? Well, they're in a plaster for 6 weeks because they're proper injuries, a boot for 6 weeks after that, and then getting back to training and proper stuff at 3 to 6 months. So it's a significant injury. Fortunately, grade 3 injuries like that are very rare in athletes as an athletic injury. Sometimes you get athletes that are involved in car crashes and so on, but that's usually a career-ending problem. So how do they do? Well, low energy injuries do extremely well, particularly in athletes. High energy displaced injuries obviously do poorly, and we're just glad to get them back walking on a stiff, rigid foot. We know that delay in treatment and litigation worsens the prognosis. Only the vast majority, well, not the vast majority, 50% apparently, but the ones I see, most patients have some signs of osteoarthritis at a year after these type of injuries, but only something like 1 in 10 actually need a fusion operation for the arthritis. Most athletic patients go back to sport at about 3 to 4 months with the grade 1, grade 2 injuries. Unfortunately, grade 3 injuries are rare in athletes. So the most important thing is we need to raise our index of suspicion for the mild ones, because when the grade 2, 3 injuries are missed, they do badly. Early diagnosis and treatment gets excellent results. And as I've said, athletes with low energy injuries do well, and high energy injuries do badly. Thank you.
Hi, I'm Ali Narvani. I'm one of the shoulder and elbow consultants at Fortius. I specialize in all aspects of shoulder and elbow surgery, in particular sports and arthroscopic procedures. It is a common issue, shoulder pain in swimmers, and there are some papers quoting figures as high as 87% of competitive swimmers will suffer at some stage from a disabling shoulder pain. What are the pathologies we're dealing with? Well, yes, they do get all the other pathologies that everyone else gets, such as longicular bicep abnormalities, rotator cuff tears, labral tears, ACJ pain, and arthritis osteochromially. But by far, the main issue is supraspinatus tendinopathy and impingement in the vast majority of the patients. Okay. Now, this is the problem with the shoulder, and it's emphasized in swimmers probably it's more the case with swimmers than other groups. The problem with shoulders is condition A can lead to condition B, which can lead to condition C. And if you just focus on condition C without addressing condition A and treat condition C, you won't be doing that patient any good. You got to look for the primary condition and address that. Primary impingement is the commonest condition. Primary impingement is the commonest condition that we surgeons treat with arthroscopic subacromial decompression. Okay? But it's probably not as common as we think it is. And it is important that when you get particularly young patients who you think they have impingements, try to look for other causes that are leading to secondary impingements. And there's a whole wide range of things. I do apologize from, this is quite a busy slide, but inadequate muscular stabilizations of scapula, glenohumeral instability, muscle imbalance, these all can lead to impingement. And if you don't address these and just address the impingement, then you probably won't have happy patients. Okay? So let's go back to the impingement. So yes, primary tendinopathy, primary impingement, yes, but there are also secondary tendinopathy impingements. And in order to look at these, we've got to consider the technique, the muscular fatigue, laxity, and other issues that can lead to these secondary tendinopathies. Why is tendinopathy, supraspinatus tendinopathy, so common in swimmers? Well, particularly in competitive swimmers. This is White Hart Lane. Okay, I don't support Tottenham, but I have nothing against people who do. But the reason I'm showing you this slide is that the capacity of White Hart Lane is 30,000 people. Okay, and that's the number of rotations a competitive swimmer will make in a week. All right, 30,000 rotations. So if a competitive swimmer will swim between 60 to 80,000 meters per week, and if you calculate it with a typical count of 8 to 10 strokes per 25 square meters, it comes to approximately 30,000 rotations in 1 week. All right, so there's a huge stress on the shoulders, which can result in repetitive micro trauma. Damage to the tendons and damage to the cells can lead to tendinopathy and impingement. All right. And if you actually look at the evidence, the number of hours swum appears to be directly linked to the frequency of supraspinatus tendinopathy. So there appears to be a direct link between how hard they train and how often supraspinatus tendinopathy occurs. Let's look at freestyle. I can cover everything, but we are limited in time, so I'm just going to cover freestyle, which is probably the commonest stroke with shoulder issues. We can, broadly speaking, we can divide a freestyle stroke into 3 phases: a hand entry, a pull-through phase where the water is in the end, and actually it's the most important phase because you're basically the athlete is pulling the body over the water in the pull-through phase. And then the hand exit followed by recovery. Okay? So these are the three main phases in a freestyle stroke. 70% of the symptoms are felt in the first half of the pull-through. Okay, this phase where the athlete is generating a lot of forces to pull the water, to pull the body over to make it. It's the engine phase of the stroke. And during this phase, in the pull-through phase, the scapula is protracted while the humerus is adducted, extended, and internally rotated. And the power is achieved through the adductors, extenders of the shoulders, and internal rotators, such as the serratus anterior, the latissimus subscapulari. Okay, so these are the main muscles in that pull-through phase where the most injuries are most common and pain is felt more often. As these muscles fatigue, swimmers get pain. Also, additionally, these muscles stabilize the scapula, and as they fatigue and they're not working as efficiently, the scapula is not moving in an efficient way, and they get secondary impingement. Okay? So it becomes a sort of a vicious circle. If you look at the technique and some of the abnormal techniques in a bit more detail. So, drop the elbow during the pull-through. So in a normal, correct position during the pull-through, the elbow is much higher than the wrist and the hand. An incorrect position, if you look at that, the position of the elbow is lower than what it is here, and the hand and the wrist are slightly higher than that. Okay? That puts all the muscles that I've talked about at a disadvantage. They're lengthened, they're at a disadvantage, they're not at their optimal contraction length. So it's more likely that they will fatigue earlier. Okay, and this is a very common mistake in the freestyle. Similarly, in the recovery phase, again, the correct position of the elbow is above the hand and wrist. This is called a dropped elbow during recovery. You can see the elbow is below the hand and the wrist. And what this leads to is an upward force on the humerus. Okay, as the arm touches the water, there's an upward force on the humerus, which causes a superior translation and secondary impingement. All right. Again, this is not an uncommon finding in swimmers with shoulder pain. Head carrying angle. The head during the pull-through should be in the water, should not be looking forward. As you look forward, in this case, because of the muscles that are used to extend your neck, you're preventing it, you're tightening the scapula, and you're preventing the scapula from moving in its normal way. Therefore, again, leading, if the scapula is not mobilizing in the normal way, again, that can lead to a secondary impingement as well. So these are the things that one should look for when one's faced with swimmers with shoulder pain. Hand entry position. So, in a correct hand entry would be the hand enters somewhere between the head and the shoulder. Okay, it shouldn't enter here. It shouldn't enter lateral to the shoulder. It shouldn't enter near the head. It should be somewhere between that. A medial hand entry is very common. All right, and if you look at this position, this is not too dissimilar to the Hawkins test that we do for impingement. So this is an impingement position. Yeah. So again, one should look for this. the way the hand enters the water, whether you bring in, whether all the fingers touch the water initially or whether you're going in with a thumb. So the correct position is all the fingers entering the water, not the thumb. The thumb enters later. Whereas an incorrect position would be, rotating your forearm with the thumb entering. And this produces excessive forces to where the long bicep attaches to the superior labrum. And it can cause damage down there. Again, during the pull-through, if you look at the position of the arm, in a correct position would be a straight arm as opposed to a bent elbow down here. And again, this is not too dissimilar to the Hawkins test that you do. Again, so again, it's sort of impingement type thing. Additionally, in order to increase the resistance, a lot of swimmers, competitive swimmers, are encouraged to practice with hand pedals. And that also has the result of increased forces on the structure of the shoulder, therefore increasing the likelihood of injuries and tendinopathies. Most of the swimmers have increased thoracic kyphosis and a hyperlordosis of lower back. Okay? And that also leads to a scapular dyskinesia and a reduced and secondary impingement as a result of reduced subacromial space. It has been shown that swimmers, and also it's not only swimmers but also throwers, have a lax anterior capsule as compared to the posterior structure. And hyperlaxity, mild anterior hyperlaxity, can in turn lead to secondary mechanical impingement as well. Now this is essentially a tight posterior inferior capsule. It's very popularized in America. They refer to it as glenohumeral internal rotation deficit, and they get it quite often with baseball throwers. And basically what happens as a result of repetitive hyperextension and abduction, as with throwers, the capsule posteriorly becomes tight. Because of the tight posterior capsule, the humerus is pushed anteriorly and superiorly, and it causes secondary internal impingement, and also it may also, in worst cases, cause damage to the rotator cuff with partial thickness tears of the rotator cuff and also superior labral slap lesions. And again, the treatment with this is not actually jumping in and repairing the cuff or the slap lesion. It's actually by trying to address the tight posterior inferior capsule. Okay. How often do we see these errors, these technical errors in competitive swimmers? Well, quite often. This is not this is a recent article, and it looked at videos of 30 American college swimmers, both under and over the water. And these are 61% of the swimmers had dropped elbow posture during the pull-through. Again, over 50% had a dropped elbow during the recovery phase. And they also reported that it was quite common to see a combination of these abnormalities together. So it is quite common. You see them quite common. And also, this is another issue. Swimmers, competitive swimmers, think that shoulder pain is part of their thing. They think that it's normal. And a lot of them put up with it, and they do not address it, and it just gets worse and worse and worse. This is a big issue. So looking at everything that we discuss, etiological factors, we can divide them into intrinsic and intrinsic factors. Extrinsic factors include, the training volume, technical errors, perhaps hand paddlers, whereas intrinsic factors include things like general hyperlaxity, thoracic kyphosis, posture, scapular dyskinesia, tight posterior inferior capsule, rotator cuff imbalance, and general lack of flexibility. Okay. And this is a paper in 2010 which actually divided swimmers with shoulder pain into categories. And he said that, they said that the best way to treat them is by dividing them into categories. So there are 5 main types. Type A or 1. These are those who have primary impingement, a mechanical impingement. Type B, it was those with internal impingement or a reduced internal rotation, the tight posterior inferior capsule. Type C, they said this is where you have a combination of A and B. Type D are those with hyperlaxity. And type A, E, they grouped everyone else. So what should be our strategies to manage these patients? Prevention is the main thing, and then treatment. Prevention actually is a lot easier than when they actually have the issue. So, one should take prevention more seriously. And it involves recognizing the incorrect technique, as mentioned before, extensive programs of stretching, strengthening, endurance training, and then careful monitoring of training as well as addressing the other muscles, core muscles. Treatment, well, again, the same correction of the poor technique, adjustment of the training volume and intensity, looking for primary reasons, and managing the primary causes of impingement. Physical therapy, maybe a course of non-steroidal anti-inflammatories, injection, surgery. Your input comes in initial modalities and physical therapies to address pain, trying to correct the posture, try to correct the tight anterior chest wall, try to address the hypomobility of the thoracic spine, try to address those with excessive joint mobility and a tight posterior inferior capsule, general rotator cuff and prescapular balance and strengthening are the issues that one needs to look at. And the last, if they don't respond, then surgery in the form of subacromial decompression. So, what could divide the phases of shoulder pain in swimmers into 3? Phase 1, this is patients who get pain only at the time of swimming, okay? And you could manage this with slight period of rest, reduced training, ice packs, correction of, analyzing their technique and trying to correct them, trying to address the instability of the core and scapula, exercises directed towards the specific dysfunction, trying to address the tight posterior inferior capsule. Phase 2 are those patients who also get pain when they're not swimming. And again, everything you do in phase 1 plus a longer rest probably from swimming, non-steroidal anti-inflammatories, and you may consider sending the patients for an injection. But only one. I don't believe in giving more than one injection, because you can do more damage than good. That's my mentality. And phase 3 is if, despite managing patients with in phase 2, if that hasn't helped at all, and if that has, if they have been symptomatic for more than 3 months, and then you do everything in phase 1, and then you consider surgery. And surgery It depends on how you classify those patients. So in type 1, where there was mechanical primary impingement, you consider decompression. Type B, you may consider repairing the labrum, repairing the partial thickness tear, as well as addressing the tight posterior inferior capsule. Type C was a mixture of both intrinsic and intrinsic impingement, so you can do a mixture of both. Type D were the instability type, hyperlaxity types, which you may want to consider capsular application. And type E was this other bag with the other host of conditions which you can address with surgery, each one of those conditions. So in summary, shoulder pain is common in swimmers. Okay? Technical error is also common, even in high-level competitor swimmers. Best treatment is prevention. Treatment is mainly non-operative. Okay?
Hello, I'm David Hargreaves. I'm a consultant hand, wrist and elbow surgeon. I treat common hand problems as well as the rare injuries that affect professional sports people. The area of treatment that is requires people to be very precise with the diagnosis, careful interpretation of scans, as well as the very intricate, precise surgery that is associated with it. So what we're going to talk about today is a number of injuries that I see from different water sports. I'm going to break this up into two groups. Those of the sports that occur from going into the water and those that are more on the water. Going into the water can be quite a forceful activity. It's hardly surprising that even when you dive from just 1 metre, you're hitting the water at nearly 20 miles an hour. And the impact onto the water with the surface tension of the water can be really very significant. So it's not surprising that people like these guys diving from the 10-metre board actually almost universally have had bad experiences and hurt themselves whilst training or in competition. It's quite interesting how you become a diver. In our area where I do some of my NHS work, which is down in Southampton, the elite group of schools for the diving go round the schools and ask how high your parents are. It's all about the height. And if you're relatively short, they will choose you because it's only the relatively short sports people who can make that amount of rotations in that limited amount of time to be able to become one of these elite athletes. It also commonly occurs in the immature skeleton as they're growing. The repetitive trauma that occurs from hitting the water is not dissimilar to those gymnasts who from a young age are learning to tumble and sustaining repetitive problems, which can therefore damage the physeal part of the bone. There are specific injuries that occur, and the things that I as an upper limb surgeon see particularly are when the thumb gets caught and gets pulled back and sustain a sudden disruption of the ligament. Classically, the ulnar collateral ligament is the most crucial. Because it's usually occurred as a single episode, one gets something similar to that we expect in the skier, hence the skier's thumb. Those are very important, particularly if the joint opens up by a long way, more than 60 degrees in the very early phase. If it opens up by a lot more than 60 degrees in the very early phase, the first week or so, one can get not just a complete tear, but a disruption where the ligaments don't go back to sit appropriately. And therefore, those patients, the ligaments cannot heal. That's what we call a stena lesion. And in that group particularly, we need to think about immediate early surgery. So if that's the case, more than 60 degrees, make sure they get referred at an early stage. We will come back later to the more chronic problem. In the wrist, it's not uncommon. I've had an elite patient with a scaphoid fracture, and it's similar to sustaining a fracture or a scapholunate ligament rupture that one can get just due to the sudden hyperextension that they get. In the elbow, the sudden forced flexion of the elbow as they're hitting the water makes the elbow bend, although they are trying to maintain a straight elbow to be able to improve their entry into the water. And they can sustain ruptures to the triceps. I've had a couple of these, which are otherwise very rare injuries. Otherwise occur in weightlifters, usually when it's going wrong. I find that there are different groups. There are those who are just mucking about in a swimming pool, and they can sustain anything. There are people jumping up and down, landing, people diving into water and hitting the bottom of the pool. All those sorts of things are not uncommon. There is also the injury where you're hitting a rope and your finger gets caught and pulled out. Now, they're quite difficult because patients often, or a little finger, gets pulled out. And one needs to be aware of the possibility of a collateral ligament injury in that sort of scenario. And the way to look for that is not immediately obvious, because the hand normally has a lot of movement with the fingers in extension. One needs to bend the fingers to 90 degrees, and then the collateral ligaments are tight. At that point, there should not be any lateral or ulnar movement of the fingers. So that is how to look for radial collateral ligament injuries in the hand from whatever sport. But there is this new sport called underwater rugby, which is a even more brutal sport than water polo, where they do this sort of thing. With a snorkel and mask, you go underwater and it's sort of three-dimensional water polo, which sounds absolutely outrageous. But as you note, this chap has got his fingers strapped up. That's because there is a specific injury that occurs in this specific sport. And this specific sport and this specific injury has made me rethink the whole cause of the hook of hamate fracture, because these guys get hook of hamate fractures. We're going to come back to his fingers strapped in a moment. The hook of the hamate fracture most commonly occurs either because of a fall over the top of a handlebar, classically landing on your hand, and the impact that's associated with that. Many of us all associate it, though, with the golfers and swinging, and what some people think of as a stress injury, either from a handle of a golf club or of a tennis racket, and presumed that it is due to the impact of the racket or the club against the hook of the hamate. But we've decided already that there is no fall, there is no handlebar or club to impact against the hook of hamate, and yet these guys get this injury. Why? The reason is because when we actually look at the clinical tests, other than localized tenderness directly over the hook of the hamate, which there's the pisiform, hook of hamate is just a little bit distal and a little bit radial. The other test other than localized tenderness is what we call the right test, where in ulnar deviation, slight flexion, you flex the little finger and the FDP pulls on that tendon, or it pulls on the hook of hamate as it pulls round. So you do that, and it's made me twig that actually a lot of hook of hamate fractures are actually occurring because of the pull from FDP. And I'm certain that that is actually what's happening in the golfers. The tennis racket is held most commonly with the little finger, which is the thing which holds the racket in the right place. And on impact, that's exactly what's happening. The same in the golfers. It is not because of the bang from the racket. It is actually holding the racket. And there you are. Look at that position that he's holding that ball in. It's exactly what we've described in the right test. So I think that's rather interesting. So thanks to Underwater Rugby, it has brought forward an understanding of a misconception that we had before. Hook or hammock fractures, if you do get them, can be treated most commonly non-operatively. Immobilisation. Most commonly people put them in splints, but actually, now that we begin to actually understand a bit more of the pathology and suddenly are beginning to twig this might be due to FDP, actually what we need to do is to stop them from bending their little fingers. So actually maybe taking them and immobilising them in radial deviation and maybe strapping their fingers up or immobilising their fingers with it straight in radial deviation may improve the outcome of non-operative treatment. And then there's the sort of slightly more sexy answer, which is the idea of fixation, which is putting a little screw right down the middle of a very little bone. But actually that's nonsense, that's bonkers, because actually that is the gold standard. The crushed finger is a common problem. Because the crushed fingertip, the thing that you really need to be aware of is, as you can see, the nail popping back out. It's very rare to be as dramatic and as yucky as that, so I do apologise. But it's not uncommon that a little bit of the nail is sticking out, and if that's the case, they do badly. You need to make sure that's reduced. So if you see what you think may be a bit of the nail, make sure it's referred to be put back in. Again, on boats, there's quite a high instance of falls, which classically will lead to the outstretched hand. Sometimes even in some of these big, in the southern oceans, I've had professional sailors who, holding on to things as they were falling, rupture their biceps tendons. And so there are injuries such as that that can occur. The other group, which was alluded to earlier, which I see, is very similar to the types of injuries that you get from horse riders, where their fingers are wrapped, where the rein is wrapped around the fingers, the horse suddenly pulls, and you get a sudden ulnar deviation of a finger, or an avulsion. Avulsions, total avulsions, like ring avulsions, you've got to be so careful. There are a number of these injuries which occur in ladies with rings on. The most important thing is to get the ring off immediately. In the canoeing world, I've seen a number of patients who have had, again, a very rare injury that you don't normally see. And that was that they were getting pain in and around the ulnar collateral ligament. They denied any injury, but it was stopping them from paddling and being able to perform their activities as well. And it was interesting because I looked into the history and I said, well, what particular bit of your canoeing is a real problem? And both these patients said, well, actually it's backpedaling and trying to reverse the boat or to turn the canoe. And then when you actually think about what they're doing, it starts to become increasingly understandable what their injury is, because as they're pushing there is significant force from the paddle. And both these patients had some instability and pain on stressing the ulnar collateral ligament. Now, they do not have what we were talking about before, which was a skier's thumb. These guys have developed what we all originally learned as gamekeeper's thumb. And gamekeeper's thumb is a slow stretching of the ligament compared to the skier's thumb, which is an acute rupture. In the chronic slow stretch, you can treat these very well non-operatively by just avoiding the activity, a splint, like a thermoplastic splint, maintaining a good posture, and rest. And it will settle back down and heal again. It does need 3 to 4 months before they go back. Or when they go back to their canoeing, they need to have some support, strapping or a splint of some form to protect it. The other group where there is a very specific injury that occurs from rowing, that occurs from the sport, is rowing. There is a ridiculous rowing race that occurs every other year where people row across the Atlantic for fun. 50% of people who finish that race end up with the same symptoms in their forearm, which is, as many of you may guess, is what's called the intersection syndrome. The intersection syndrome is what many people would have thought was a de Quervain tenosynovitis, i.e. a tenosynovitis, of course, of the first dorsal compartment, but it occurs very slightly more proximally. What happens is that they get the rubbing of the thumb extensors running over the wrist extensors. And that causes an inflammation at this site, which can be treated, again, non-operatively, with rest, splint, avoiding the activity, ice in the early phase, and many and often that will settle down. If it doesn't settle down, then sometimes a steroid injection and very rarely surgical intervention with a release of the fascial bands between those two muscles at that site usually cures it. It's quite interesting because, of course, in London you'll see lots of people going to the gym and sustaining such an injury, so be aware it's not so uncommon. Other sports, I've just had the number 3 badminton player in Britain who's just come to me with exactly this problem. Interesting. So it does occur from other sports as well, but very common in the rowers. There is another type which you should be aware of, though, with this, which is a patient who sustains a sudden tearing sensation with sudden bruising at exactly this site. And it's quite interesting because in those patients, it usually cures this condition because there is often some fibrous tissue which is just tethering these two groups of muscles together. And what happens is in that tearing sensation is they've automatically torn it spontaneously in an injury which may have occurred. Actually, it occurred, one person who I've seen was water skiing and fell when this suddenly happened. They thought something awful happened. Actually, they had been having some symptoms of intersection syndrome, but then never again after this episode. So it is quite interesting, this, that. From water skiing, there are other injuries that you can get, particularly exertional compartment syndrome, chronic compartment syndrome in the hands, also classically occurs in the windsurfers, as well as the tennis players, semi-pro tennis players who've upped the amount of tennis they're playing may develop such conditions. Being aware of the condition is half the battle. Also, another rare injury that I've seen in water skiers is when they fall and their arm goes into the rope and the rope gets wrapped around them and they can sustain biceps muscle injuries, which almost only occurs in water skiers and parachutists when a rope goes across it in a high force injury. So actually taking a good history, being aware of the of what's going on, being aware of different conditions and being very precise about where the site of maximal pain and how to reproduce those is the crux of making the correct diagnosis. And that is the most important thing in hand surgery. Thank you.